So thank you, Bill. It is an honor and privilege always to speak at a Mayo Clinic CME program. I'd like to thank Dr. Britton and Dr. Tatum for organizing this. My remarks will be restricted to the evaluation and treatment of patients with epilepsy or suspected seizures utilizing video-EEG monitoring, and by way of disclosure, these are my personal and professional activities. We know that epilepsy is very common, probably over 200,000 new patients in the US per year, and many more are seen for paroxysmal clinical episodes that may represent seizures. If we look at the sobering report of the Institute of Medicine, 1 in 26 Americans will have a seizure disorder in their lifetime, and this is double the number of patients combined with autism spectrum disorders, multiple sclerosis, and Parkinson's disease. So it's important when we look at research dollars, clinical interest, and a public health care problem, we're aware of how common a seizure disorder is. 10% of the individuals in this room will experience one seizure during their lifetime. We know that over 3 million Americans have a seizure disorder, 500,000 children, and many more patients are seen by you as physicians and healthcare providers with suspected epilepsy. The EEG is good, as we've heard in the excellent lectures earlier today, but it's problematic. We're using medication that may make it less likely to see specific patterns. It's insensitive in some patients. It's nonspecific. And at best, we may record interictal findings that only point or suggest the diagnosis of epilepsy. So if a patient comes in with an appropriate neurologic history, and you do this EEG recording, and you see robust left temporal sharp waves and spikes, you may have the diagnosis and do not need to listen to the next 30 minutes on adult video-EEG monitoring. But unfortunately, there are limitations. And these numbers don't necessarily conflict with my colleague, but importantly, patients may have normal EEG recordings and have a seizure disorder. If you do multiple EEG recordings, you increase the yield. If you bring a patient into a long-term epilepsy monitoring unit and don't record seizures, you increase the yield. And in healthy flight personnel, the number is relatively low. Here are patients who may have normal EEG studies in your practice. One, they don't have epilepsy. And that's a significant number. It may be challenging to many of you, but a number of individuals receiving anti-epileptic drug therapy have non-epileptic conditions.